Welcome back to the deep dive. Prepare to immerse yourselves in a fundamental aspect of human anatomy, the incredible, intricate bones that make up your upper limb.
It's something we use constantly, isn't it? The arm, the hand, the structure underneath is just amazing.
It really is. And here's a fact that might just drop your jaw right at the start. Out of the 206 bones that form your entire skeleton, a massive 64 of them reside in your upper limbs alone.
64, that's almost a third.
Exactly. Nearly a third of your bone structure just dedicated to the incredible versatility of your arms and hands. What's even more fascinating, and a real efficiency bonus if you're studying anatomy, is the symmetry. You master the detailed anatomy of the bones on one side, say your left upper limb.
Right.
And congratulations, you've essentially mastered the bones on the right side too. It's like getting two for the price of one when you really understand the structure.
That bilateral symmetry is one of the elegant principles of biological design, really. It allows for incredible complexity and functionality just mirrored on each side.
Absolutely. And for this deep dive, we have a clear mission. You, our listener, have provided us with a stack of detailed anatomical sources focusing specifically on the bones of the upper limb. Our goal today is to unpack everything in these sources. We're going to methodically work our way from the shoulder down to the fingertips, exploring the clavicle, the scapula, the humerus, the radius, the ulna, the complex array of carpal bones in the wrist, the metacarpals that form the palm, and the phalanges of your fingers and thumb.
You're not just naming parts.
No way. We want to understand their specific features, see exactly where muscles and ligaments anchor, grasp how these bones develop over time, and crucially, understand what happens when things go wrong clinically, what injuries are common, and why.
Right.
Think of this as working towards the level of detailed understanding that the elite professionals in this field possess. We're going to explore every concept and cover every detail in the text, aiming for true mastery of this specific anatomical region.
Precisely. We'll be guiding you through this material, highlighting those crucial nuggets of information, helping you connect the dots between structure, function, and clinical relevance, and making sure we cover the full depth provided in your sources.
Okay, so let's jump right in, starting with that often underappreciated bone, the clavicle. It's sometimes called the collarbone, right? And the source kicks things off by telling us it's classified as a long bone.
Yes, the clavicle from the Latin for small key. And it's a truly unique long bone right from the start because, well, unlike all other long bones, which are oriented vertically in anatomical position, the clavicle lies horizontally.
Ah, horizontal. That's the first odd thing.
It is. Its fundamental role, as laid out in the source, is to act as a strut. It supports your shoulder, basically holding it laterally away from your trunk.
So it keeps the shoulder out to the side.
Exactly. This support is absolutely essential because it lets your arm swing clear and perform that huge range of movements it does without bumping into your side. Without that clavicular strut, your shoulder would just kind of collapse inwards.
Right.
Beyond just support, it's also the primary bone for transmitting weight from your upper limb. That load gets channeled through the clavicle and passed inwards towards the sternum, which is part of your axial skeleton, your body's central pillar.
Okay, a horizontal strut for support and weight transfer. Got it.
No.
Now, before we get into its features, how do we even tell if a clavicle is from the left or right side? That seems like a basic but necessary step for understanding the anatomy.
Well, the sources give us three clear ways to determine the side. First, you look at the ends. The end that points away from your body laterally is flattened.
Okay.
The end closest to your midline, medially, is much larger and has a distinct quadrilateral, sort of four-sided shape.
So flattened out wide, big and squarish near the center.
That's the idea. Second, observe the curvature of the shaft. It's not straight, you see. As it moves from the medial end outwards, the shaft curves convexly forwards for about 2/3 of its length. Then, for the lateral 1/3, the curve reverses and goes concave forwards.
So picture it arching forward near your chest, then curving slightly backward as it reaches the shoulder. Convex forward medially, concave forward laterally.
That's the shape. And third, you examine the inferior surface, the underside of the bone. There's a noticeable longitudinal groove running along the middle 1/3 of the shaft. That groove is another key indicator for side determination.
Okay, flattened lateral end, large medial end, the distinctive double curve, and a groove on the bottom. That gives us our orientation. But you mentioned it's unique, truly peculiar.
Yeah.
What makes the clavicle stand out so much among other bones? The source listed quite a few fascinating peculiarities.
Oh, this is where the detail gets really interesting. The source lists 7 distinct peculiarities. We've already mentioned it's the only long bone that lies horizontally.
Right.
But look at number 2. It's subcutaneous throughout. You can palpate or feel this bone from end to end right under your skin. Just run your fingers along your collarbone, that's the clavicle, easily accessible.
Right, you can feel the whole thing. Easy.
Precisely. Then we move to its development. It is the very first bone in the entire body to begin the process of ossification, or bone formation.
The first one.
The first. This starts incredibly early, between the 5th and 6th week of intrauterine life.
Wow. First bone to start forming? Ahead of the spine, the skull, everything.
Yes, it kicks things off. And coupled with being first, here's another peculiarity. It's the only long bone that ossifies mainly in membrane.
What does that mean exactly?
Well, most long bones develop through endochondral ossification, where cartilage models are replaced by bone. The clavicle largely bypasses that cartilage stage and forms bone directly from connective tissue membranes. It's a different process.
So, earliest formation and a different method than most long bones. That's quite a combination already.
It keeps going. It's also the only long bone that has 2 primary centers of ossification. Typical long bones start with just one primary center in the shaft. The clavicle has 2, which appear in the shaft relatively early and then quickly fuse together around the 45th day of development.
2 primary centers. Membrane ossification. First to start. That's 5 unusual traits already. What are the last 2?
Number 6. It has no medullary cavity. Most long bones have that central hollow space, containing bone marrow.
Right.
The clavicle is more solid bone tissue throughout its length. And finally, number 7, the source notes that in some individuals it is occasionally pierced by the middle supraclavicular nerve.
Pierced, like the nerve goes through the bone.
Literally passes through a tunnel in the bone. It's a specific anatomical variation, but it means that nerve could potentially be relevant in cases of fracture or surgery near the clavicle.
Wow. Okay. Horizontal, subcutaneous, first to ossifies in membrane, 2 primary centers, no medullary cavity, and sometimes pierced by a nerve. The clavicle is absolutely packed with unique characteristics. Understanding these peculiarities gives us a much deeper appreciation for this bone beyond just its shape.
It truly does. And we can tie some of these peculiarities back to its function.
Right.
Let's elaborate on that weight transmission role. The source explains that weight from the upper limb is transmitted via the lateral 1/3 of the clavicle, with the crucial connection being made by the corticoclavicular ligament.
Ah, that ligament.
Yes, it essentially acts as a bridge, taking the load from the scapula and transferring it to the clavicle. From there, the medial 2/3 of the clavicle then transfers that load inwards to the sternum, linking the limb to the rest of the skeleton.
So the corticoclavicular ligament isn't just an attachment, it's a key component in the structural chain of weight bearing.
Precisely. Now let's break down the detailed features of the bone itself, starting with that curved shaft. We noted it has a lateral 1/3 and a medial 2/3.
Right.
The lateral 1/3 is flattened from superior to inferior. It presents 2 borders. The anterior border, which is concave and points forwards, and the posterior border, which is convex and points backwards. The superior surface is that easily palpable subcutaneous area. The inferior surface is where we find those specific features important for ligament attachment. The conoid tubercle, named for its cone shape, and the trapezoid ridge.
Distinct bumps and ridges on the underside of the outer part, and the medial 2/3.
The medial 2/3 of the shaft is more rounded and is described as having 4 surfaces. The anterior surface follows that larger forward convex curve. The posterior surface is smooth. The superior surface is somewhat rough, particularly towards the medial end. And the inferior surface has a rough oval impression medially, another site for ligament attachment, and laterally, that longitudinal subclavian groove we used for side determination.
Okay. And the nutrient foramen, the entry point for blood vessels, where's that?
The nutrient foramen for the shaft is located at the lateral end of that subclavian groove on the inferior surface of the medial 2/3. The source notes it transmits a branch of the suprascapular artery.
Got it. A lot packed onto that shaft. Now, the ends. We know one's flat, one's big and quadrangular. What are their specific features?
The lateral, or acromial end, acromion, meaning the peak of the shoulder is flattened. It bears a smooth articular facet, a surface designed to articulate with the acromion process of the scapula. This articulation forms the acromioclavicular joint, often just called the AC joint.
The AC joint.
Yes. The medial or sternal end is the larger quadrangular shaped end. It articulates with the clavicular notch on the manubrium sterni, the upper part of your breastbone. This forms the sternoclavicular joint.
Okay.
The source adds a detail here. The articular surface extends downwards to articulate with the first costal cartilage, essentially linking it firmly to both the sternum and the first rib.
So it's not just connected to the sternum, but also the first rib's cartilage.
Yeah.
Making that sternoclavicular joint a very robust connection point. It's the only bony link between the upper limb and the axial skeleton, which really highlights its importance, doesn't it?
Absolutely. It's the crucial link. Now, let's map out where muscles and ligaments attach to this busy bone, referencing the figures from the source.
Yeah.
At the lateral end, the margin of the articular facet for the acromioclavicular joint simply gives attachment to the fibrous capsule of that joint.
Straightforward enough. What about the medial end?
The medial end is an anchorage point for structures involved in the sternoclavicular joint. The margin of its articular surface gives attachment to the fibrous capsule of the sternoclavicular joint all around. On the posterior superior aspect, it attaches to the articular disc of that joint, and superiorly, it provides attachment for the interclavicular ligament, a band that connects the medial ends of both clavicles across the top of the sternum.
Okay. Joint capsules and key ligaments at the ends.
Yeah.
What attaches to the shaft? Let's break that down.
We'll go section by section. On the lateral 1/3 of the shaft, the anterior border gives origin to the deltoid muscle, that large muscle forming the rounded contour of your shoulder. The posterior border provides insertion for the trapezius muscle, one of the large muscles of your upper back and neck. And those features on the inferior surface, the conoid, tubercle, and trapezoid ridge. They are crucial for the attachment of the conoid and trapezoid parts of the coracoclavicular ligament, that vital ligament for weight transmission we discussed earlier.
So deltoid and trapezius on the borders and that key ligament underneath. Got it. What attaches to the medial 2/3 of the shaft?
This is a site for some significant muscle origins. Most of the anterior surface provides origin for the pectoralis major, your main chest muscle.
Okay.
On the rough superior surface, the clavicular head of the sternocleidomastoid, a prominent neck muscle, takes origin. The oval impression on the inferior surface medially gives attachment to the costoclavicular ligament, linking the clavicle to the first rib below it. The longitudinal subclavian groove laterally is the insertion point for the subclavius muscle, a small muscle located just below the clavicle. The margins of that groove also give attachment to the clavipectoral fascia, a fascial layer. Finally, the smooth posterior surface, close to the medial end, gives origin to the sternohyoid muscle, one of the strap muscles in the neck.
That's an impressive list of muscles. Pectoralis major, sternocleidomastoid, subclavius, sternohyoid, plus key ligaments anchored to this one bone. It's like a central hub.
It is indeed a central hub for the shoulder girdle. The source also points out specific structures that are closely related to the clavicle by passing deep to its inferior surface, nestled between it and the upper surface of the first rib.
Things running underneath it.
Exactly. And these are critical structures. The subclavian vessels, meaning the subclavian artery and vein, and the divisions of the trunks of the brachial plexus, the massive bundle of nerves that supplies your entire upper limb.
Wow, major stuff.
Major stuff. The subclavius muscle also lies in this area, potentially acting as a cushion. And we noted earlier that the nutrient foramen transmits a branch of the suprascapular artery.
So vital nerves and major vessels are literally just below this bone, protected by it, but also potentially vulnerable if the bone is injured. This brings us neatly to the clinical anatomy, doesn't it?
Absolutely. The clavicle is unfortunately one of the most frequently fractured bones in the body. The common mechanism is indirect violence, most often a fall on the outstretched hand.
Right, the classic Fuchs injury.
Exactly, fall on outstretched hand. The most frequent site of fracture is at the junction of its two curves, where the medial convex part meets the lateral concave part. The source specifically calls this the weakest point of the bone, both structurally and because the two opposing curves concentrate stress there.
That makes perfect sense. The point where the structural geometry changes is often where it's most vulnerable, like bending a wire back and forth.
Precisely. And when this common fracture occurs, the displacement of the fragments is often characteristic. The lateral fragment, the piece towards the shoulder, is typically displaced downwards.
Line downwards.
The anatomical reason provided in the source is that the trapezius muscle, which attaches to that fragment, simply cannot support the full weight of the upper limb by itself. The support from the clavicular strut is gone.
So the shoulder literally droops because the main support beam is broken. The clinical anatomical problem in the source, describing the 50-year-old cyclist with the drooping shoulder after a fall, is a perfect illustration of this mechanism and consequence.
It makes the why behind the physical presentation very clear. The source also touches on congenital issues related to the clavicle, specifically cleidocranial dysostosis. This is a genetic condition where the clavicles are congenitally absent or imperfectly developed. As you might expect, without this crucial strut developed correctly, the clinical presentation is striking. The shoulders droop significantly, and individuals can often approximate their shoulders forwards in front of their chest, as shown in the figures provided.
Wow, they can almost touch their shoulders together in front. If that bony support isn't present from birth, the entire shoulder girdle isn't properly anchored. Fascinating, and underscores just how critical this unique bone is. All right, let's transition posteriorly now and examine the scapula, the bone we commonly call the shoulder blade.
The scapula, it's a relatively thin, flat, somewhat triangular bone situated on the posterolateral aspect of your thoracic cage resting against your ribs. It's a complex bone featuring 2 surfaces, 3 borders, 3 angles, and 3 distinct processes.
2 surfaces, 3 of everything else. How do we determine if a scapula is from the left or right side? It seems more complex than the clavicle.
Well, the source gives us 3 key characters again. First, locate the lateral or glenoid angle. This is the large, broad corner of bone, and it bears the glenoid cavity, that shallow socket that articulates with the head of the humerus.
The socket for the arm bone. Okay.
Yes. Second, look at the surfaces. The dorsal surface, the back of the scapula, is convex and is notably divided by a prominent ridge, the spine of the scapula.
Right, you can feel that some.
You can. The costal surface, the front side facing your ribs, is occupied by the subscapular fossa, a broad concave area shaped to fit the convex curve of your chest wall.
So the back is bumpy with the spine, the front is smooth and curved inwards to match the ribs.
Exactly. And third, identify the thickest border. This is the lateral border, which runs from the glenoid cavity at the top down to the inferior angle at the bottom. The other borders are relatively thin.
Okay, lateral angle with the socket, bumpy dorsal surface with the spine, concave costal surface, thickest lateral border. That clearly gives us the side. Let's delve into the specific features of these surfaces, borders, angles, and processes now.
Starting with the surfaces. On the costal surface, the subscapular fossa is concave and directed medially and forwards. It's marked by 3 longitudinal ridges. But the source highlights particularly thick ridge that runs along the lateral border of the surface.
A thick ridge on the front, near the armpit side.
Exactly. This section of bone is almost rod-like and serves a crucial purpose. It acts as a lever arm, providing increased mechanical advantage for the crucial serratus anterior muscle, especially during powerful actions like overhead abduction of the arm.
So that thick lateral ridge on the front isn't just random. It's specifically shaped to enhance the function of a key muscle. That's a great example of form-following function.
Absolutely. It optimizes the muscle's ability to protract and rotate the scapula. Now, on the dorsal surface, we see the spine of the scapula, that triangular plate projecting posteriorly. It divides the surface into the smaller supraspinous fossa above and the larger infraspinous fossa below.
Supra above, infra below the spine.
Right. The posterior border of the spine forms the crest, which has upper and lower lips for muscle attachments. The source also points out the sphenoglenoid notch, a notch lateral to the root of the spine that connects the supraspinous and infraspinous fossa.
Connecting the areas above and below the spine.
Yeah.
What about the borders? There are 3.
Yes. The superior border is the shortest. Near the root of the coracoid process, the beak-like projection, there's the suprascapular notch.
Yeah.
The lateral border, that thickest one, has the infraglenoid tubercle at its upper end, just below the glenoid cavity. The medial border is thin and runs vertically from the superior angle to the inferior angle, parallel to the spine.
Got it. And the angles?
Yeah,
2 corners.
the superior angle is located where the superior and medial borders meet. It's typically covered by the trapezius muscle. The inferior angle, where the medial and lateral borders meet, is covered by the latissimus dorsi muscle. The source notes that the inferior angle moves forwards around the chest wall when you abduct your arm, which is a visible part of the scapulohumeral rhythm, the coordinated movement between the scapula and the humerus during arm elevation.
You can actually see that bottom corner of the shoulder blade swing out when you lift your arm high.
You can. The lateral or glenoid angle, as we identified earlier, is the broad part bearing the glenoid cavity, directed forwards, laterally, and slightly upwards. Above the glenoid cavity is the supraglenoid tubercle.
So the movement of the inferior angle is a visible clue to how the scapula is participating in arm motion. What about the processes we mentioned? The spine, acromion, and coracoid. Let's detail those.
The spine or spinous process is that large triangular plate dividing the dorsal surface. Its posterior border forms the crest, with distinct upper and lower lips for muscle attachment. Projecting laterally from the spine is the acromion process.
And forms the bony tip of the shoulder.
Exactly. It has two borders, medial and lateral, two surfaces, superior and inferior, and that articular facet on its medial border for the clavicle, forming the AC joint. Finally, the coracoid process projects forwards and slightly laterally from the superior border. It's described as bent and finger-like, its name derived from the Greek for crow's beak.
Looks like a little bent finger pointing forward.
It does. The source adds that it's considered an atavistic type of epiphysis, meaning it's thought to be a remnant of a more prominent structure in our evolutionary ancestors.
Another interesting detail hinting at evolutionary history. All right, this bone is clearly a major anchor point. Let's get into the numerous muscle and ligament attachments, referencing the figures from the source. This might take a minute.
It's quite a list, starting with the muscles that fill the fossae. The subscapularis, a large multipennate muscle, arises from the medial 2/3 of the subscapular fossa on the costal surface. On the dorsal surface, the supraspinatus arises from the medial 2/3 of the supraspinous fossa, including the upper surface of the spine. The infraspinatus arises from the medial 2/3 of the infraspinous fossa, including the lower surface of the spine. These three, along with teres minor later, are key components of the rotator cuff.
Muscles filling those hollows on both sides. Got it. What about muscles attaching to the borders and processes?
The deltoid muscle arises from the lower border of the crest of the spine and the lateral border of the acromion process. The trapezius muscle is inserted into the upper border of the crest of the spine and the medial border of the acromion. The serratus anterior muscle is inserted along the medial border of the costal surface, with its digitations attaching from the superior angle down to the inferior angle. This widespread attachment is what allows it to effectively protract and rotate the scapula, using that lever we talked about.
Right, the muscle that prevents winging.
Exactly. The long head of the biceps brachii arises from the supraglenoid tubercle, just above the glenoid cavity. The short head of the biceps brachii arises from the lateral part of the tip of the coracoid process. Right next to it, the coracobrachialis arises from the medial part of the tip of the coracoid process. The pectoralis minor muscle is inserted into the medial border and superior surface of the coracoid process. The long head of the triceps brachii muscle arises from the infraglenoid tubercle, just below the glenoid cavity.
So the biceps and triceps, primary arm movers, have heads anchored firmly to tubercles on the scapula, top and bottom of the socket. What about the muscles on the lateral and medial borders?
The teres minor muscle arises by two slips from the upper 2/3 of the rough strip along the lateral border on the dorsal surface. The source notes the circumflex scapular artery passes between these slips.
Okay.
The teres major muscle arises from the lower 1/3 of that same rough strip on the dorsal aspect of the lateral border. It's worth noting that the latissimus dorsi muscle arises from the inferior angle itself. Along the medial border on the dorsal aspect, the levator scapulae is inserted from the superior angle down to the spine root. The rhomboid minor is inserted into the medial border opposite the root of the spine, and the rhomboid major is inserted into the medial border between the root of the spine and the inferior angle. Finally, the inferior belly of the omohyoid muscle arises from the upper border near the suprascapular notch.
That's an incredible concentration of muscle origins and insertions covering nearly every edge and surface of the scapula. It's truly the base of operations for movements of both the arm and the shoulder blade itself. What about ligaments attaching here?
The margin of the glenoid cavity gives attachment to the capsular ligament of the shoulder joint and the glenoidal labrum, a fibrocartilaginous ring that helps deepen the socket.
The labrum, like a lip.
Exactly. The margin of the facet on the acromion process gives attachment to the capsule of the acromioclavicular joint. The coracoacromial ligament attaches between the lateral border of the coracoid process and the medial side of the tip of the acromion process. The coracohumeral ligament attaches to the root of the coracoid process, and the coracocollicular ligament, which we saw anchoring to the clavicle, attaches to the coracoid process here, the trapezoid part superiorly, and the conoid part near the root.
Connecting clavicle to scapula via the coracoid. What about the transverse and spinoglenoid ligaments? They sound specific.
They are. The transverse ligament is a band that bridges across the suprascapular notch on the superior border, converting it into a foramen, a hole.
Uh-huh.
The suprascapular nerve passes through this foramen, while the suprascapular vessels typically pass above the ligament. The spinoglenoid ligament may bridge the spinoglenoid notch, and if present, the suprascapular vessels and nerve pass deep to it.
Ligaments creating passages for nerves and vessels, another important anatomical detail. Now, how does the scapula develop? What's its ossification pattern? Seems complex.
It is. The scapula ossifies from one primary center and 7 secondary centers. The primary center appears near the glenoid cavity fairly early, during the 8th week of development, forming the main body of the bone.
Okay, the main part starts early.
Right. The secondary centers are more numerous and appear later, mostly around puberty. The first secondary center actually appears in the middle of the coracoid process during the first year and fuses around 15. A subcoracoid center appears in the root of the coracoid around 10 years and fuses between 16-18 years.
So the coracoid has a couple of its own centers.
It does. The remaining 5 secondary centers appear at puberty, 2 for the acromion, 1 for the lower 2/3 of the glenoid margin, 1 for the medial border, and 1 for the inferior angle. These later centers fuse by around 25 years.
So a main primary center and then processes and borders developing from multiple secondary centers fusing over a very long period well into adulthood.
Exactly. And the source highlights a practical clinical point related to the acromion's ossification. Since it ossifies from 2 centers that fuse later, sometimes these centers fail to unite completely.
Ah,
On a radiograph, this can be mistaken for a fracture of the acromion. The tip given is to check a radiograph of the opposite side. If it also shows a failure of union, it's likely a normal developmental variation, not a fracture.
that's a critical distinction to make clinically. Compare both sides. Good tip. Speaking of clinical points, what are the key takeaways for the scapula?
The most notable clinical issue is winging of the scapula, caused by paralysis of the serratus anterior muscle.
We mentioned that muscle attachment.
Yes, because this muscle normally holds the scapula flat against the chest wall and helps protract and rotate it using that lever arm we discussed, its paralysis means the medial border of the scapula pulls away from the chest wall, becoming unduly prominent, like a wing. This also severely limits the ability to abduct the arm beyond 90 degrees.
So a wing scapula is a strong indicator of serratus anterior paralysis and functional limitation in overhead movement.
Precisely. The source also mentions scaphoid scapula as a developmental anomaly where the medial border has a concave shape instead of being straight. Just an anatomical variation.
Got it. All right, moving inferiorly from the shoulder girdle, let's delve into the bone of the arm itself, the humerus.
The humerus. It's the longest bone of the upper limb, connecting the scapula at the shoulder to the radius and ulna at the elbow. Structurally, it has a rounded upper end, a flattened lower end, and a shaft in between.
How do we determine the side of a humerus?
The source gives us 3 criteria again. First, look at the overall shape of the ends. The upper end is rounded to form the head, while the lower end is expanded side to side and flattened from front to back.
Round top, flat bottom.
Basically. Second, the direction of the head is key. It points medially, upwards, and backwards. Imagine it correctly oriented in your body. The head is nestled into the scapula's glenoid cavity in that direction.
Rounded end up, pointing inwards, slightly upwards, and towards your back.
Okay, that's the direction. And third, on the anterior aspect of the upper end, there's a distinct elevation called the lesser tubercle. It's located medially and is limited laterally by the intertubercular sulcus, also known as the bicipital groove.
Rounded end up, head medial up back, lesser tubercle anterior with the bicipital groove next to it. That sets our orientation. Let's explore the features of these parts in more detail, starting with the upper end.
The upper end begins with the head, which is roughly 1/3 of a sphere, and articulates with the glenoid cavity of the scapula to form the shoulder joint. As we noted, the glenoid cavity is much shallower than the head, contributing to the shoulder's mobility but also its potential instability. The line separating the head from the rest of the upper end is the anatomical neck. Just below the anatomical neck are the 2 tubercles, the lesser tubercle on the anterior aspect and the larger greater tubercle on the lateral aspect. The greater tubercle has 3 distinct impressions on its upper and posterior surface, upper, middle, and lower, for muscle attachments.
3 spots on the bigger tubercle. and the groove between the tubercles.
That's the intertubercular sulcus, or bicipital groove. It runs vertically between the lesser tubercle medially and the anterior part of the greater tubercle laterally. Its medial and lateral lips are downward extensions of the lesser and greater tubercles, respectively.
Okay, anatomical neck, two tubercles, bicipital groove. What about the surgical neck? I hear that term a lot.
Yes, the surgical neck is a narrow region below the tubercles, separating the entire upper end from the shaft. This area is clinically significant because it's a frequent site of fractures.
Ah, hence the name surgical.
Likely. There's also a morphological neck, located about 0.5 centimeters below the surgical neck, which represents the position of the epiphyseal line during development.
Surgical neck, important for fractures. Got it. Let's move down to the shaft.
The shaft is generally rounded in its upper half and becomes triangular in its lower half. It has 3 borders and 3 surfaces. The anterior border forms the lateral lip of the intertubercular sulcus in its upper third, the anterior margin of the V-shaped deltoid tuberosity in its middle part, and is smooth and rounded in its lower half.
Okay.
The lateral border is only prominent at the lower end as the lateral supracondylar ridge. Superiorly, it's barely traceable, and in the middle, it's interrupted by the radial or spiral groove as it winds around.
Spiral groove. That sounds important.
It is. We'll come back to that. The medial border forms the medial lip of the intertubercular sulcus superiorly, has a rough strip in its middle, and continues below as the medial supracondylar ridge.
So the shape of the borders changes significantly along the shaft's length. What about the surfaces defined by these borders?
The anterolateral surface is between the anterior and lateral borders. Its upper half is covered by the deltoid muscle. A V-shaped elevation called the deltoid tuberosity, where the deltoid inserts, marks it slightly above the middle. Behind this tuberosity, the radial groove runs downwards and forwards across the surface.
Okay.
The anteromedial surface is between the anterior and medial borders. Its upper third is narrow and forms the floor of the intertubercular sulcus. This surface is also where the nutrient foramen is located, near the medial border below its middle. The source notes it's directed upwards. A detail we'll see fits that broader rule about bone growth.
Nutrient foramen pointing upwards on the anteromedial surface and the posterior surface.
The posterior surface is between the medial and lateral borders. Its upper part has an oblique ridge, and its middle one-third is crossed by the radial groove, which wraps around from the anterolateral surface. This groove houses the radial nerve, making this area clinically important.
So the radial groove is a key landmark on both the anterolateral and posterior surfaces in the midshaft region, and it's associated with the radial nerve.
Got it.
Let's look at the lower end now, the condyle.
The lower end is expanded side to side and has both articular and non-articular parts. The articular parts include the capitulum, a rounded surface on the lateral side that articulates with the head of the radius,
Okay.
and the trochlea, a pulley-shaped surface on the medial side that articulates with the trochlear notch of the ulna. The source points out a specific detail about the trochlea. Its medial edge projects about 6 millimeters further down than the lateral edge.
6 millimeters difference.
Yes. And this anatomical asymmetry is precisely why you have a carrying angle at your elbow, that slight angle away from the body when your arm is extended.
That's the anatomical explanation for the carrying angle.
Yeah.
A specific feature on the trochlea.
Yeah,
Fascinating.
it is. The non-articular parts include the prominent medial epicondyle on the medial side, which is subcutaneous and easily palpable. This is your funny bone.
Ah, the funny bone. The source even includes a little anonymous quote, linking the name of the humerus to hitting this spot and making someone smile.
Yes, the source notes that palpation of the ulnar nerve just behind the medial epicondyle makes some persons smile. It's a play on words, but highlights that the ulnar nerve passes in a groove directly behind that subcutaneous medial epicondyle, making it vulnerable to impacts that cause that distinctive tingling or painful sensation down the arm.
So hitting the medial epicondyle is actually hitting the ulnar nerve resting in a groove behind it. That makes the anatomy of the funny bone crystal clear. What about the lateral epicondyle?
The lateral epicondyle is smaller, located on the lateral side, and has a muscular impression anterolaterally for muscle origins. Just above these epicondyles are the sharp lateral and medial supracondylar ridges, which are extensions of the shaft borders.
Mm-hmm.
On the anterior aspect of the lower end are 2 depressions. The coronoid fossa, located above the trochlea, which receives the coronoid process of the ulna during elbow flexion, and the radial fossa, above the capitulum, which receives the head of the radius during elbow flexion. On the posterior aspect is the large olecranon fossa above the trochlea, which receives the olecranon process of the ulna during elbow extension.
So fossae, or hollows, on the front and back to accommodate the forearm bones when the elbow bends and straightens. Let's map out the numerous muscle and ligament attachments on the humerus now, using the source figures.
Okay, starting at the upper end, on the tubercles and in the bicipital groove. The multipennate subscapularis muscle inserts into the lesser tubercle. The supraspinatus muscle inserts into the uppermost impression on the greater tubercle. The infraspinatus muscle inserts into the middle impression on the greater tubercle. The teres minor muscle inserts into the lower impression on the greater tubercle.
That's the rotator cuff group, right? Or most of it.
3 of the 4 main ones, yes. These last 3 are the SIT muscles, supraspinatus, infraspinatus, teres minor, key components of the rotator cuff that insert on the greater tubercle, enabling rotation and stabilization of the shoulder.
SIT for supraspinatus, infraspinatus, teres minor on the greater tubercle, and subscapularis on the lesser.
Got it. Correct.
Yeah.
Now, muscles inserting into the intertubercular sulcus. The pectoralis major muscle inserts into the lateral lip of the sulcus. The source specifies this as a bilaminar insertion, meaning the tendon attaches in 2 layers.
Okay.
The latissimus dorsi muscle inserts into the floor of the sulcus, and the teres major muscle inserts into the medial lip.
Ah, the lady between 2 majors mnemonic comes in handy here. Latissimus dorsi on the floor, between pectoralis major on the lateral lip and teres major on the medial lip.
Exactly. The contents of the intertubercular sulcus itself are the tendon of the long head of the biceps brachii muscle, enclosed in a synovial sheath, and the ascending branch of the anterior circumflex humeral artery.
So the long head of the biceps tendon runs right in that groove. Makes sense why it's called the bicipital groove, what attaches to the shaft surfaces and borders.
The deltoid muscle inserts into the V-shaped deltoid tuberosity on the anterolateral surface. The cora brachialis muscle inserts into the rough area on the middle of the medial border. The brachialis muscle, a powerful elbow flexor deep to the biceps, arises from the lower halves of the anteromedial and anterolateral surfaces of the shaft and even part of the posterior surface.
Big origin for the brachialis. What about muscles originating from those supracondylar ridges we identified?
The brachioradialis muscle arises from the upper 2/3 of the lateral supracondylar ridge. The extensor carpi radialis longus muscle arises from the lower 1/3 of the lateral supracondylar ridge. And the humeral head of the pronator teres muscle arises from the lower 1/3 of the medial supracondylar ridge. These are forearm muscles originating higher up on the humerus.
Right, and the epicondyles themselves are major origin points, aren't they? The common origins.
They are indeed common origin sites for large muscle groups controlling the forearm and hand. The anterior aspect of the medial epicondyle is the site of origin for the superficial flexor muscles of the forearm, known as the common flexor origin. The lateral epicondyle is the site of origin for the superficial extensor muscles of the forearm, plus the supinator muscle, the common extensor origin.
So flexors from the medial epicondyle, extensors from the lateral epicondyle, nice anatomical grouping. What's on the posterior surface?
The anconeus muscle arises from the posterior surface of the lateral epicondyle. And the triceps brachii muscle, the primary elbow extensor, has 2 heads originating from the posterior humerus shaft. The lateral head arises from the oblique ridge on the upper part of the posterior surface above the radial groove.
Okay.
And the medial head arises from the posterior surface below the radial groove.
Triceps on the back for extension, biceps and brachialis on the front for flexion. That functional separation is clearly reflected in their bony attachments. What about ligaments attaching to the humerus?
The capsular ligament of the shoulder joint attaches to the anatomical neck, except on the medial side, where its attachment dips down about 2 centimeters onto the shaft, incorporating a small area of the shaft into the joint cavity.
Right, you mentioned that detail.
Yes. The source also points out that the line of attachment is interrupted at the intertubercular sulcus, creating an aperture for the tendon of the long head of the biceps brachii to pass out of the joint cavity. This specific detail is important for understanding the shoulder joint's complex structure.
So the shoulder capsule isn't just a neat line around the anatomical neck. It's more complex, extending down medially and having an opening for the biceps tendon. That's crucial.
Exactly. For the elbow joint, the capsular ligament attaches to the lower end of the humerus along a line that reaches the upper limits of the radial and coronoid fossa anteriorly, and the olecranon fossa posteriorly. This means those three fossa are actually located inside the elbow joint capsule.
Okay.
Medially, the attachment passes between the medial epicondyle and the trochlea, and laterally between the lateral epicondyle and the capitulum.
So the elbow capsule incorporates the fossa, but leaves the bulk of the epicondyles outside the joint.
Correct. Now, let's connect this anatomy to clinical reality. The source highlights three major nerves that are in such close proximity to the humerus that they are particularly vulnerable to injury if the bone fractures.
The ARM mnemonic, I remember that one.
That's the one. The axillary nerve is intimately related to the surgical neck, making it vulnerable in fractures there. The radial nerve follows the radial groove on the midshaft, putting it at risk in midshaft fractures. And the ulnar nerve is located directly behind the medial epicondyle, making it susceptible to injury in fractures or severe impacts to the elbow region. Remember that funny bone sensation? That's the ulnar nerve.
Axillary nerve at the surgical neck, radial nerve at the midshaft, the radial groove, and ulnar nerve behind the medial epicondyle. Those are crucial nerve-bone relationships to remember because injury to the bone can easily mean injury to the nerve.
Absolutely. Now let's look at how the humerus develops its ossification. The humerus ossifies from one primary center and 7 secondary centers. The primary center appears in the middle of the diaphysis, the shaft, during the 8th week of development. The upper end ossifies from 3 secondary centers. One for the head appears first, around the 1st year. One for the greater tubercle appears around the 2nd year, and one for the lesser tubercle appears around the 5th year.
Head, greater, lesser tubercle.
Right. These 3 centers fuse together relatively early, around the 6th year, to form a single compound epiphysis. This compound epiphysis then fuses with the shaft much later, around the 20th year.
So the components of the upper end fuse together relatively early, but that whole piece takes much longer to join the main shaft.
Yes. The source points out that the epiphyseal line for the upper humerus is located at the level of the lowest margin of the head. This is identified as the growing end of the bone, the end that contributes more to lengthwise growth and fuses later. And as we noted earlier, the nutrient foramen on the shaft is directed upwards, which we'll see aligns with the general rule. The nutrient foramen points away from the growing end.
Growing end at the top, nutrient foramen points away.
Got it. What about ossification at the lower end? You said 7 secondary centers in total.
Yes, so 4 for the lower end. It's more complex down there, ossifying from 4 centers which eventually form 2 epiphyses, 3 centers, one for the capitulum and the lateral flange of the trochlea, appearing around the 1st year, one for the medial flange of the trochlea, around the 9th year, and one for the lateral epicondyle around the 12th year, fused together around the 14th year to form a compound epiphysis.
Okay.
This compound epiphysis then fuses with the shaft relatively early, around 16 years. However, the center for the medial epicondyle appears earlier, around 4-6 years, forms a separate epiphysis, and fuses with the shaft much later, around the 20th year, similar to the upper end.
So the lower end's ossification is quite intricate, with parts fusing at different times and the medial epicondyle following its own later timeline. That's complex. It is detailed, and understanding these timelines is important when looking at pediatric radiographs, for instance. Now, back to the clinical anatomy of the humerus. Beyond the nerve injuries, what are the common fractures?
Right.
The source lists common fracture sites as the surgical neck, the shaft, and the supracondylar region, the area just above the elbow joint. Supracondylar fractures are particularly common in young children, often caused by a fall on the outstretched hand with the elbow slightly flexed.
Okay.
A frequent displacement is that the lower fragment of the humerus is pushed backwards. This can make the elbow joint appear unduly prominent posteriorly, sometimes looking similar to an elbow joint dislocation.
So the fracture can mimic a dislocation because the bone piece shifts position.
Yeah.
That could be confusing.
Exactly, causing a visual deformity that needs careful assessment. The source points out that this type of fracture may injure the median nerve. Crucially, it can also be complicated by Volkmann's ischemic contracture.
Ah, you mentioned that briefly. What is it exactly?
It's a very serious condition caused by occlusion or blockage of the brachial artery, which runs near the humerus. The lack of blood flow to the forearm muscles causes severe muscle damage and leads to permanent contracture and deformity of the hand and wrist. It's a devastating complication.
Volkmann's ischemic contracture, highlighting the danger to nearby vessels in fractures. That's critical. The source also refers to assessing the elbow bony points. How does that help?
Yes, the relationship between the lateral epicondyle, the tip of the olecranon process, and the medial epicondyle. In a normally flexed elbow, these 3 points form an equilateral triangle.
Okay.
In a normally extended elbow, they fall in a straight line. This precise relationship is disrupted in elbow joint dislocations, providing a quick clinical test to help differentiate between a fracture and a dislocation.
That's a classic bedside or emergency room check. Simple but effective.
It is. The source also mentions that the shaft of the humerus has a relatively poor blood supply at the junction of its upper 1/3 and lower 2/3. Fractures specifically at this site are known for experiencing delayed union or non-union, meaning they take a long time to heal or may fail to heal altogether due to inadequate blood flow.
Poor blood supply in that specific region impacts healing. Good to know.
Yeah.
And shoulder dislocations.
The head of the humerus most commonly dislocates inferiorly below the glenoid cavity. This is termed a subglenoid dislocation.
Okay. That covers a lot of ground on the humerus, from its structure and attachments to its development and common injuries. Now let's move down the arm and explore the two bones of the forearm, starting with the radius.
The radius. It's the more lateral bone of the forearm, located on the thumb side when your hand is in the anatomical position.
Right.
The source tells us it's considered homologous with the tibia in the lower limb, indicating a similar developmental origin and position in the limb structure. It consists of a rounded upper end, a broad lower end with a styloid process, and a shaft connecting them.
How do we determine the side of a radius bone?
The source provides 4 criteria. First, examine the ends. The upper end has a disc-shaped head and a narrow neck, while the lower end is expanded and features a pointed styloid process projecting downwards. Also, the radial tuberosity is located near the neck at the upper end.
Disc head up, styloid process down.
Right. Second, look at the lower end surfaces. The anterior surface has a prominent, thick ridge, while the posterior surface is marked by 4 grooves for extensor tendons.
So a thick ridge on the front of the lower end, grooves on the back.
Exactly. Third, the lower end also has a notable bony projection on its posterior surface called the dorsal tubercle of Lister. And fourth, feel or observe the borders of the shaft. The sharpest border is the medial border, also known as the interosseous border.
Disc head up, expanded lower end with styloid process, radial tuberosity near the neck, anterior ridged posterior grooves on the lower end, Lister's tubercle on the back of the lower end, and sharpest border is medial. That gives us the side. Let's detail those features, starting at the top.
The upper end starts with the head, a disc-shaped structure covered with hyaline cartilage. Its superior surface is concave and articulates with the capitulum of the humerus to form part of the elbow joint. The circumference of the head is also an articular surface, fitting into the radial notch on the ulna and enclosed by the annular ligament. This forms the superior radial ulnar joint, which is essential for the radius's rotation during pronation and supination.
So the radial head articulates with both the humerus and the ulna, allowing for hinge movement and rotational movement. Very clever.
Precisely. The neck is the narrow part just below the head and is enclosed by the lower margin of the annular ligament. The source points out that the head and neck are free from any capsular attachment, which is why they can rotate freely within that fibro-osseous ring formed by the ulna's radial notch and the annular ligament.
Yeah.
Just below the medial part of the neck is the radial tuberosity. It has 2 distinct parts, a rough posterior part and a smooth anterior part.
Why the different surfaces on the radial tuberosity? Smooth and rough.
Good question. The rough posterior part is the insertion point for the powerful biceps brachii muscle. The smooth anterior part is covered by a bursa, a small fluid-filled sac that minimizes friction between the tendon insertion and the bone during movement. So the rough part is for the strong tendon attachment, and the smooth part facilitates gliding with the bursa.
That functional differentiation explains the two parts beautifully. Makes sense. What are the shaft's features?
The shaft has 3 borders, anterior, posterior, and the sharp medial interosseous border in 3 surfaces. The anterior border runs from the radial tuberosity down to the styloid process. In its upper half, it's oblique and called the anterior oblique line. In its lower half, it's more vertical and sharp, becoming crest-like at its very lowest part. The posterior border is a mirror image of the anterior border, but is only clearly defined in its middle 1/3. Its upper oblique part is called the posterior oblique line. The medial, or interosseous border, is the sharpest border. It runs from the radial tuberosity down at the posterior margin of the ulnar notch at the lower end. The strong interosseous membrane is attached to its lower 3/4. In its lower part, it forms the posterior margin of an elongated triangular area.
So the interosseous border is where the strong membrane connecting the radius and ulna anchors. What about the surfaces?
The anterior surface is located between the anterior and interosseous borders. The nutrient foramen is found in its upper part and is directed upwards. The source says its artery is a branch of the anterior interosseous artery. This upward direction aligns with the general rule for nutrient foramen we'll consolidate later.
Right.
The posterior surface is between the posterior and interosseous borders. The lateral surface is between the anterior and posterior borders and presents a roughened area in its middle part.
Nutrient foramen on the anterior surface, pointing up. Consistent. What about the broad lower end? You said it has 5 surfaces.
Yes, the lower end is the widest part of the radius and has 5 surfaces. The anterior surface has that thick, prominent ridge we used for side determination. This ridge is clinically important because the radial artery is palpated against it when you take the radial pulse at the wrist.
So the anterior surface of the lower radius is literally what you feel your pulse against. That's a great landmark.
Exactly. The posterior surface presents 4 grooves which accommodate the extensor tendons of the forearm and hand. The dorsal tubercle of Lister, a key bony landmark at the wrist, lies lateral to an oblique groove on this surface.
Lister's tubercle.
Yes. The medial surface features the ulnar notch, which articulates with the head of the ulna to form the inferior radial knot joint. The lateral surface is prolonged downwards to form the pointed styloid process. And the inferior surface is crucial as the main articular surface for the wrist joint itself. It's divided into 2 areas, a triangular area laterally for the scaphoid bone and a medial quadrangular area for the lunate bone.
So the lower radius forms the proximal part of the main wrist joint, articulating directly with 2 carpal bones, the scaphoid and lunate. Let's detail the muscle and ligament attachments here.
Okay, the biceps brachii is inserted into the rough posterior part of the radial tuberosity, as we mentioned. The supinator muscle inserts into the upper part of the lateral surface of the shaft. The pronator teres muscle inserts into the middle of the lateral surface. The brachiradialis muscle inserts into the lowest part of the lateral surface, just above the styloid process.
Biceps on the tuberosity, supinator, pronator teres, brachiradialis on the lateral shaft. Got it.
Yes. For muscles arising partly from the radius, the radial head of the flexor digitorum superficialis originates from the anterior oblique line and the upper part of anterior border. The flexor pollicis longus, the long thumb flexor, originates from the upper 2/3 of the anterior surface. The pronator quadratus muscle, a square muscle in the distal forearm, is inserted into the lower part of the anterior surface and the triangular area on the medial side of the lower end. As mentioned, the radial pulse is felt on the anterior surface of the lower radius, with the pronator quadratus lying deep to it.
More detail on that pulse location, linking it to the underlying muscle. What about muscles originating from the posterior surface?
The abductor pollicis longus and the extensor pollicis brevis, 2 muscles that move the thumb outwards and extend it, arise from the posterior surface of the radial shaft and the interosseous membrane. Ligament attachments include the quadrate ligament attached to the medial part of the neck of the radius, and the oblique cord attached on the medial side just below the radial tuberosity. The articular capsule of the wrist joint is attached to the anterior and posterior margins of the inferior articular surface. The articular disc of the inferior radial ulnar joint is attached to the lower border of the ulnar notch. The extensor retinaculum, a thick band that holds the extensor tendons down at the wrist, is attached to the lower part of the sharp anterior border of the radius.
A comprehensive map of muscle and ligament attachments. You mentioned the interosseous membrane attaching to the interosseous border. What's its function beyond just binding the bones? Why is it there?
That's a great question. The interosseous membrane is a strong fibrous sheet that connects the interosseous borders of the radius and ulna along most of their length. Its primary functions are to firmly bind the radius and ulna together, maintaining their relative position. And crucially, to transmit forces received by the radius from the hand upwards to the ulna. This allows the ulna, which doesn't directly articulate with the carpal bones, except via the articular disc, to share in weight bearing through the elbow joint.
So it distributes force between the 2 forearm bones, making the ulna participate in loads coming from the hand, even though it doesn't touch the wrist bones directly. Very clever system. You detailed those 4 grooves on the posterior surface for extensor tendons. The source describes the tendons within all 6 compartments formed by the extensor retinaculum. Can we run through those? Seems important for hand function.
Yes, understanding these compartments is key to the anatomy on the back of the wrist. The extensor retinaculum is a thick band stretched across the back of the wrist, with septa extending down to the radius, ulna, and interosseous membrane, forming 6 tunnels or compartments for the extensor tendons. 4 of these compartments are specifically associated with grooves on the posterior surface of the radius.
Okay, 6 compartments. Let's hear them.
The first compartment lies between the sharp crest-like lowest part of the anterior border and the styloid process of the radius. It contains the tendons of the abductor pollicis longus and extensor pollicis brevis, APL and EPB.
Thumb muscles.
Right. The second compartment is located between the styloid process and the Lister's tubercle on the radius. It transmits the tendons of the extensor carpi radialis longus and extensor carpi radialis brevis, ECRL and ECRB.
Wrist extensors.
Exactly. The third compartment is in the oblique groove, just medial to Lister's tubercle on the radius. It contains the tendon of the extensor pollicis longus, EPL.
Another thumb muscle.
Yes, the long one. The fourth compartment is located on the medial aspect of the posterior radius. It's the largest compartment and transmits the tendons of the extensor digitorum, ED, and extensor indicis, EI, along with the posterior interosseous nerve and anterior interosseous artery.
Finger extensors plus nerve and artery.
Correct. The fifth compartment is situated at the junction of the lower ends of the radius and ulna. It transmits the tendon of the extensor digiti minimi, EDM.
Little finger extensor.
And the sixth compartment is located in a groove on the posterior aspect of the ulna between its head and styloid process. It transmits the tendon of the extensor carpi ulnaris, ECU.
Last wrist extensor on the ulna side. That's a very detailed anatomical guide to the extensor tendons at the wrist, crucial for understanding conditions like tenosynovitis or surgical approaches.
Yeah.
Now, how does the radius ossify?
The shaft of the radius ossifies from a primary center appearing during the 8th week of development. It has 2 secondary centers, one for each end. The secondary center for the lower end appears quite early during the first year of life.
Okay.
However, it fuses with the shaft much later, around 20 years of age. This identifies the lower end as the growing end of the radius. Consistent with the rule, the nutrient foreman on the shaft points upwards, away from this late fusing growing end.
Right.
The secondary center for the upper end, the head, appears later, around the 4th year, and fuses with the shaft earlier, around 18 years.
So the lower end appears first, but fuses last, making it the primary growing end. The upper end appears later, but fuses earlier. This follows that law of ossification you mentioned. Now, for the clinical anatomy of the radius, it's known for a specific fracture, right?
Yes, the radius is notorious for a very common fracture, especially in adults and older individuals, occurring about 2 centimeters above its lower end. This is known as Collas fracture.
Collas fracture.
It's typically caused by falling on the outstretched hand. The characteristic displacement in a Collas fracture is that the distal fragment of the radius, the part closer to the hand, is displaced upwards and backwards. A classic sign is that the radial styloid process, which normally extends further distally than the ulnar styloid, comes to lie proximal to the ulnar styloid.
So the pointy bit on the thumb side moves up relative to the pointy bit on the little finger side.
Exactly. This backward and upward displacement creates a visible deformity, often described as a dinner fork deformity.
Dinner fork deformity that paints a vivid clinical picture of a Collas fracture.
Yeah.
Very memorable.
It does. The less common reverse Collas is called Smith's fracture, where the distal fragment is displaced anteriorly. Another important clinical condition related to the radius, particularly in young children, is pulled elbow, or subluxation of the head of the radius.
Pulled elbow.
Yes. This is usually caused by a sudden, forceful jerk on a child's hand while their arm is extended. This sudden traction can partially dislodge the head of the radius from the grip of the annular ligament that holds it against the ulna at the superior radial honor joint. The source notes that the head of the radius can normally be felt in a hollow behind the lateral epicondyle of the humerus when the elbow is extended.
So a strong pull on a young child's arm can cause the radius head to slip out of its ligamentous socket. That's a valuable piece of information for anyone caring for young children.
Ouch. It is. Now let's move to the ulna, the other bone of the forearm on the medial side.
The ulna is the medial bone on the little finger side. The source tells us it's homologous with the fibula in the lower limb. It has a large upper end with 2 prominent processes, a shaft and a narrow, rounded lower end.
Right. How do we determine the side of the ulna bone?
Okay, the source gives us 3 criteria here. First, look at the upper end. It's large and hook-like, and the concavity of that hook is directed forwards.
Like a wrench shape facing forward.
Exactly. Second, examine the shaft's borders. The lateral border is notably sharp and crest-like along most of its length.
The interosseous border again.
Right. Third, look at the lower end. The pointed styloid process is located posteromedial to the rounded head of the ulna at its lower end.
Hook-like upper end facing forward, sharp lateral border, styloid process posteromedial to the head at the bottom. Got it. Let's detail the features of that large upper end. It looks quite complex.
It is. The upper end is dominated by the olecranon and coronoid processes and the large trochlear notch and smaller radial notch. The olecranon process is the large upward projecting part that forms the point of your elbow.
The bit you lean on.
Yes, it has superior, anterior, posterior, medial, and lateral surfaces. The anterior surface is articular and forms the upper part of the trochlear notch. The posterior surface is a large triangular subcutaneous area separated from the skin by a bursa. This is the point of the elbow. The medial and lateral surfaces blend with the shaft, and the superior surface has a roughened posterior part.
So the olecranon forms the palpable elbow point, is covered by a bursa posteriorly, and is a major articular surface anteriorly. What about the coronoid process?
The coronoid process projects forwards from the shaft just below the olecranon, resembling a crow's beak, hence its name. It has 4 surfaces. The superior surface forms the lower part of the trochlear notch. The anterior surface is triangular and rough, and its lower corner forms the ulnar tuberosity. The lateral surface features the radial notch, an articular surface for the head of the radius. The annular ligament attaches to the margins of this notch. Below the radial notch, the lateral surface is depressed to accommodate the radial tuberosity of the radius and is limited posteriorly by a ridge called the supinator crest. The medial surface is continuous with the shaft.
So the coronoid process is crucial for both elbow articulation, trochlear notch, and articulating with the radius, radial notch, plus muscle attachments like the brachialis and supinator.
Precisely. The trochlear notch is that large articular surface formed by the anterior surface of the olecranon and the superior surface of the coronoid process. It's shaped like a wrench and articulates with the trochlea of the humerus, providing the stable hinge movement of the elbow joint. The radial notch, located on the lateral side of the coronoid process, is the articular surface specifically for the circumference of the head of the radius, forming the superior radial ulnar joint.
That large, hook-like upper end is clearly designed for the ulna's primary role as the stabilizing bloom of the forearm, gripping the humerus tightly. Let's look at the shaft.
Okay, the shaft has 3 borders and 3 circulars. The interosseous or lateral border is the sharpest, particularly in its middle 2/4. It runs from the supinator crest above down to the lateral side of the head below. This is where the interosseous membrane attaches.
Right.
The anterior border is thick and rounded, starting on the medial side of the ulnar tuberosity and passing downwards, curving slightly backwards in its lower third, and terminating at the medial side of the styloid process. The posterior border is subcutaneous, running from the apex of the subcutaneous area on the back of the olecranon down to the base of the styloid process.
Subcutaneous posterior border, like the clavicle.
Interesting.
And the surfaces.
The anterior surface is between the anterior and interosseous borders. It features the nutrient foramen in its upper part, directed upwards. The source notes this nutrient artery is also derived from the anterior interosseous artery, matching the pattern in the radius. The medial surface is between the anterior and posterior borders. The posterior surface is between the posterior and interosseous borders, and is subdivided into 3 areas by oblique and vertical lines.
Nutrient foramen on the anterior surface, pointing up consistent with the pattern in the other long bones. What about the lower end of the ulna? It seems much smaller than the upper end.
It is. The lower end consists of the head and the styloid process. The head is rounded and articulates with the ulnar notch on the medial side of the radius to form the inferior radial ulnar joint.
Right, for pronation supination.
Exactly. A critical anatomical point here is that the head of the ulna is separated from the actual wrist joint by a triangular fibrocartilaginous articular disc.
Ah, the TFCC.
Yes. This means the ulna does not directly articulate with the carpal bones. The ulnar artery and ulnar nerve lie on the anterior aspect of the ulnar head. The styloid process is a pointed projection extending downwards from the posteromedial side of the head. Posteriorly, there's a groove between the head and the styloid process, which transmits the tendon of the extensor carpi ulnaris muscle, fitting into the 6th extensor compartment we listed earlier.
So the ulna's lower end articulates with the radius, but that disc keeps it out of the main wrist joint. The radius is the primary forearm bone articulating with the carpus. That's a key difference. Let's get into the muscle and ligament attachments on the ulna now.
Okay. The triceps brachii muscle is inserted into the rough posterior part of the superior surface of the olecranon process. with the anterior part covered by a bursa. The brachialis muscle is inserted into the anterior surface of the coronoid process, including the ulnar tuberosity. The supinator muscle arises from the supinator crest and the triangular area in front of the crest on the lateral side of the coronoid and upper ulna. The ulnar head of the flexor digitorum superficialis muscle arises from a tubercle at the upper end of the medial margin of the coronoid process. The ulnar head of the pronator teres muscle arises from the medial margin of the coronoid process.
Triceps on the olecranon, brachialis, supinator, and parts of FDS and pronator teres on the coronoid and upper shaft. Got it.
Yes, the flexor digitorum profundus, the deep flexor muscle for the fingers, has a very extensive origin from the ulna. It arises from the upper 3/4 of the anterior and medial surfaces of the shaft, the medial surfaces of the coronoid and olecranon processes, and from the posterior border of the shaft via a strong aponeurosis.
Wow, that's a huge origin.
It is, and this aponeurosis is also notable because it gives origin to parts of two other muscles, the flexor carpi ulnaris and the extensor carpi ulnaris.
An aponeurosis on the posterior border of the ulna serving as an origin point for three different muscles: flexor digitorum profundus, flexor carpi ulnaris, and extensor carpi ulnaris. That's an interesting shared origin. Very efficient design.
It really is. The pronator quadratus muscle originates from the oblique ridge on the lower part of the anterior surface of the ulna. The ulnar head of the flexor carpi ulnaris arises from the medial side of the olecranon process and the posterior border, sharing that aponeurosis origin. The extensor carpi ulnaris also arises from the posterior border, again via that aponeurosis. The anconeus muscle is inserted into the lateral aspect of the olecranon process and the upper 1/4 of the posterior surface of the shaft.
The ulna is clearly a major anchor for many of the muscles controlling forearm and hand movement. What about muscles arising from the lateral part of the posterior surface?
From superior to inferior, the abductor pollicis longus, extensor pollicis longus, and extensor indicis muscles arise from the lateral part of the posterior surface of the ulna and the interosseous membrane.
Thumb and index finger muscles.
Right. Ligament attachments include the interosseous membrane attached to the interosseous border and the oblique cord attached to the ulnar tuberosity. The capsular ligament of the elbow joint is attached to the margins of the trochlear notch, essentially wrapping around the coronoid and olecranon processes. The ulnar collateral ligament of the wrist joint is attached to the styloid process, and the articular disc of the inferior radial-ulnar joint is attached by its apex to a small, rough area just lateral to the styloid process of the ulna.
Plenty of attachments to stabilize the ulna and anchor muscles. How does the ulna ossify?
Okay, ossification. The shaft and most of the upper end of the ulna ossify from a primary center appearing during the 8th week of development. The superior part of the olecranon process ossifies from a secondary center that appears much later, around the 10th year. It forms a scale-like epiphysis that joins the rest of the bone by the 16th year.
Scale-like epiphysis. Interesting.
Yes. The lower end ossifies from a secondary center appearing during the 5th year, and this center joins with the shaft by 18 years. The source identifies this lower end as the growing end of the ulna, which aligns with the nutrient foramen on the shaft pointing upwards, away from it.
So the ulna's primary growing end is at the bottom, like the radius, but its olecranon also has a later appearing epiphysis. Let's look at the clinical points for the ulna now. What's its main role?
As we discussed, the ulna's primary role is as the stabilizing bone of the forearm. Its trochlear notch provides a tight, stable grip on the humerus, creating the strong hinge joint of the elbow. This stability allows the radius to effectively pronate and supinate around it for hand positioning.
It provides the fixed axis for forearm rotation. That makes sense.
Exactly. The shaft of the ulna can fracture alone or in combination with a radius fracture.
Yeah.
If both bones are fractured, it's critical to prevent cross-union abnormal bony bridging between the two bones, because this would severely limit or completely abolish the essential movements of pronation and supination.
Right. You'd lose that rotation.
You would. Dislocation of the elbow joint typically involves the ulna displacing posteriorly relative to the humerus. This is produced by a fall on the outstretched hand with the elbow slightly flexed. The olecranon process shifts backwards and the elbow becomes fixed in a position of slight flexion.
This relates back to the disrupted relationship of the elbow bony points we discussed earlier. The triangle line is broken. It helps differentiate.
Yes. Fracture of the olecranon process is common, usually resulting from a fall directly on the point of the elbow. Fracture of the coronoid process is less common and usually occurs in conjunction with elbow dislocation, as it's the coronoid that limits posterior displacement. Finally, the source describes Maitland's deformity.
Madelung's deformity.
This involves dorsal subluxation, a partial displacement backwards of the lower end of the ulna. The cause is specifically retarded growth of the lower end of the radius. Because the radius isn't growing to its full length distally, the ulna effectively becomes too long in comparison and gets pushed backwards at the wrist.
So a growth problem in the radius causes the ulna to displace. That's a clear illustration of how intertwined the growth and function of these two bones are, a real functional partnership.
It really shows how they work together. We've worked our way through the major long bones of the upper limb, covering their detailed features, muscle attachments, development, and clinical relevance, just as laid out in the sources. Before we move on to the wrist and hand bones proper, the source has a specific section that consolidates some crucial points about ossification across these long bones and their clinical significance. Let's unpack that to truly master the developmental aspects.
Right, this section introduces a key principle for long bones that have epiphyses, or secondary ossification centers, at both ends. The rule, as stated in the source and sometimes called the law of ossification, is the epiphysis of the end which appears first is the last to unite with the shaft. Conversely, the epiphysis that appears last is the first to unite with the shaft.
Appear first, join last. Appear last, join first. That's the law for long bones with two epiphyses. Seems counterintuitive at first glance.
It can seem that way, but it relates to growth duration. The source designates the end whose epiphysis unites last with the shaft as the growing end of the bone. This is the end that typically contributes more significantly to the lengthwise growth of the bone. Applying this to the upper limb long bones based on the ossification timing we've discussed. The upper end of the humerus, head appearing at 1, fusing at 20 years. The lower end of the radius, appearing at 1 year, fusing at 20 years. And the lower end of the ulna, appearing at 5 years, fusing at 18 years, are identified as the growing ends. These are the ends where growth continues for a longer period and whose epiphyses are the last to fuse with the shaft compared to the other ends of those bones.
Upper humerus, lower radius, lower ulna. The growing ends where fusion happens later. That matches the patterns we saw earlier.
Precisely. And the source reiterates the rule for the direction of the nutrient foramen relative to these growing ends. The direction of the nutrient foramen in the shaft of a long bone is usually directed away from the growing end.
Away from the growing end. Let's check.
Let's check if this holds true. The humerus nutrient foramen points upwards, away from the growing upper end. The radius nutrient foramen points upwards, away from the growing lower end. And the ulna nutrient foramen also points upwards, away from the growing lower end. The rule is consistent across these bones.
This is a really neat way to remember the direction of blood supply entry in long bones. Just figure out the growing end, and the foramen points the other way. The source also references tables providing the specific timings.
Yes. Table 2.1 summarizes the approximate year of appearance and fusion for the primary and secondary centers of the humerus, radius, and ulna. It underscores the fact that fusion times are variable and that those growing ends continue developing and fusing quite late, often into the early 20s, 20 to 25 years.
So growth plates at the upper humerus and lower radius ulna are active well into late adolescence, early adulthood. This timing and location are incredibly important clinically, especially regarding infections in children, right?
Absolutely, and the source has a specific section detailing the critical importance of capsular attachments and epiphyseal lines in this context. The metaphysis is defined as the epiphyseal end of the diaphysis, essentially the portion of the shaft adjacent to the epiphyseal line, the growth plate.
Okay.
It's described as a site of actively growing bone with a rich blood supply, making it a common site for infections, particularly bacterial osteomyelitis, in young individuals. The epiphyseal line is the cartilaginous growth plate itself, the site of bone lengthening.
Metaphysis, growing area near the growth plate, rich blood supply, common site of bone infection in kids. Epiphyseal line, the growth plate itself. Got it.
Correct. The critical clinical implication arises from the relationship between these actively growing, infection-prone areas and the joint capsule. If the epiphyseal line, the growth plate, or the adjacent metaphysis is intracapsular, meaning it lies within the confines of the joint capsule.
Inside the joint lining.
Exactly. Then, an infection originating within the joint, like septic arthritis, can easily spread from the joint space into the metaphysis. Because the metaphysis is an active growth zone, infection there can damage or even destroy the growth plate, leading to disturbances or arrest of bone growth in that limb segment. Conversely, an infection starting in the metaphysis can break into the joint if the metaphysis is intracapsular.
So an infection in a child's shoulder, elbow, or wrist joint could directly reach and potentially damage the growth plate if that part of the bone is inside the joint capsule. That's a serious risk for future growth.
It is. The source provides Table 2.2 detailing these specific capsular relationships for the ends of the humerus, radius, and ulna. Let's break it down.
Okay.
For the upper end of the humerus, the capsular attachment is lateral to the anatomical neck, but dips down 2 centimeters medially, deficient only at the bicipital groove. The epiphyseal line is at the lowest part of the head's articular surface. The result is that the metaphysis is partly intercapsular.
Partly inside the shoulder joint.
Right. For the lower end of the humerus, the capsular attachment follows the margins of the fossa, radial, coronoid, olecranon. The epiphyseal line is horizontal at the level of the lateral epicondyle, though the medial epicondyle has a separate line. The metaphysis is partly intracapsular. Both epicondyles are extracapsular.
Partly inside the elbow joint, but epicondyles outside.
Correct. For the upper end of the radius, the capsular attachment is to the neck. The head itself forms the epiphysis. The metaphysis here is intracapsular.
Upper radius metaphysis is inside the elbow joint capsule.
Yes. For the lower end of the radius, the capsular attachment is close to the articular margin all around. The epiphyseal line is a horizontal line above the ulnar notch level. The metaphysis is completely extracapsular.
Lower radius growth plate is outside the wrist joint capsule.
Okay, right. For the upper end of the ulna, the capsular attachment is near the articular surface. The scale-like olecranon epiphysis is on the superior surface. The metaphysis and part of the diaphysis are related to the capsular line, but the epiphysis is extracapsular.
Upper ulna growth plate is outside the elbow joint.
Essentially, yes. For the lower end of the ulna, the capsular attachment is around the head. The epiphyseal line is horizontal at the level of the radius's articulating surface. The metaphysis is partly intracapsular.
Partly inside the distal radial inner joint capsule.
Yes. And the source summarizes the overall clinical implication. Because the metaphysis or epiphyseal line is intracapsular at the upper end of the humerus, both ends of the radius, specifically the upper end's metaphysis being intracapsular and the lower end of the ulna, joint infections in children involving the shoulder, elbow, or wrist are indeed likely to spread to the actively growing metaphysis, potentially causing growth disturbances. The elbow joint region is particularly vulnerable as it involves the ends of all 3 long bones, humerus, radius, ulna, with varying degrees of intracapsular metaphysis.
That detailed anatomical relationship between joint capsules and growth plates is a fundamental concept in understanding bone growth disorders caused by childhood infections. It really shows why detailed anatomical knowledge is so crucial in clinical practice. You need to know what's inside and outside the joint.
It's a perfect illustration of how knowing the what and where of anatomy explains the why of disease processes.
All right, having thoroughly covered the long bones and their development, let's move further distally to the bones of the wrist, the carpal bones. This is where it gets complicated, right? Lots of little bones.
It is a complex region. The carpus, or wrist, is made up of 8 relatively small bones arranged in 2 rows, a proximal row closer to the forearm and a distal row closer to the hand. The source gives us a clear listing and helpful mnemonics. The proximal row, from lateral, thumb side, to medial, little finger side, consists of the scaphoid, lunate, triquetral, and pisiform.
She looks too pretty. Scaphoid, lunate, triquetral, pisiform. I remember that one from anatomy class.
It's a classic. Their names often relate to their shape. Scaphoid, boat-shaped, lunate, half-moon or crescentic, triquetral, 3-cornered, and pisiform, key-shaped. The distal row, from lateral to medial, is the trapezium, trapezoid, capitate, and hamate.
Try to catch her. Trapezium, trapezoid, capitate, hamate. Okay.
Correct. Again, names relate to shape. Trapezium, 4-sided figure. Trapezoid, resembling a baby's shoe. Capitate, meaning head, as it's the largest carpal bone. And hamate, meaning hook, referring to a distinctive projection.
8 bones in 2 rows. How do we begin to identify these individually and orient them to determine the size? They all look kind of small and lumpy.
They can seem that way, but the source provides general identification points for all carpal bones before detailing specific features. Generally, the proximal row is convex on its proximal surface, articulating with the radius articular disc, and concave on its discal surface, articulating with the distal row.
Okay, convex top, concave bottom for the first row.
Right. The distal row is convex on its proximal surface, articulating with the proximal row, but relatively flat on its distal surface, articulating with the metacarpals. Each carpal bone typically has 6 surfaces. Most palmar, anterior, and dorsal posterior surfaces are non-articular, except for the triquetral and pisiform. The lateral surfaces of the two most lateral bones, scaphoid and trapezium, are non-articular, as are the medial surfaces of the three most medial bones, trochanterial, pisiform, hamat. Also, the dorsal non-articular surface is usually larger than the palmar, except for the lineate, where the palmar non-articular surface is larger.
So general row shape and non-articular surface patterns help us orient the bone and determine which surface is which. That helps narrow it down.
Yes, these general points help identify proximal, distal, palmar, and dorsal aspects. Then you use the specific, unique features of each bone for definitive identification and side determination.
Okay, let's go through the specific points for each of the 8 carpal bones then. Scaphoid first.
For the scaphoid, a key identifying feature is its tubercle, a bony prominence directed laterally, forward, and downwards.
Scaphoid tubercle.
Yes. The lunate is distinctive for its half-moon or crescent shape. It has a small semilunar articular surface on its lateral side for the scaphoid, and a quadrilateral articular surface on its medial side for the triquetral. The triquetral is pyramidal in shape. It has a unique oval facet on the distal part of its palmar surface, specifically for articulating with the pisiform bone. Its medial and dorsal surfaces are continuous and non-articular.
So the triquetral has a dedicated facet just for the pisiform. That's
Yeah.
a good clue. What about the pisiform itself? The P-shaped one.
The pisiform is P-shaped and unique among carpals in that it has only one articular facet, an oval facet, on its proximal dorsal surface for articulation with the triquetral. The source also notes that its lateral surface is grooved by the ulnar nerve.
The ulnar nerve running right next to the pisiform is a significant anatomical relationship. We keep coming back to that nerve.
It is. Moving to the distal row, the trapezium is quadrangular. Its palmar surface is marked by a vertical groove for the flexor carpi radialis tendon, bordered laterally by the crest of the trapezium. Its distal articular surface is critically shaped, excellar, or concavo-convex, forming a saddle joint. This specific shape articulates with the base of the first metacarpal bone, and is fundamental for the thumb's wide range of motion, particularly opposition.
That unique saddle joint between the trapezium and the first metacarpal is what gives the thumb its incredible function. That's the key joint.
Absolutely. The trapezoid is said to resemble a baby's shoe. Its distal articular surface for the second metacarpal is larger than its proximal articular surface for the scaphoid and trapezium. Its palmar non-articular surface is prolonged laterally.
Baby shoe shape, okay.
The capitate is the largest carpal bone, recognizable by its rounded head. The dorsomedial angle of the body is the distal-most projection and bears a small facet for the fourth metacarpal bone. Finally, the hamate is wedge-shaped and is identified by its prominent hook, which projects from the distal part of the palmar surface and is directed laterally.
The hook of the hamate. Can feel that one sometimes too. Each carpal bone has its own unique shape and surface features that allow for precise identification. The source also emphasizes that many important soft tissue attachments are concentrated around specific bony pillars at the corners of the carpus. What are those?
Yes, it simplifies things by highlighting 4 key bony pillars. These are the tubercle of the scaphoid and the pisiform on the lateral and medial sides of the proximal row,
Okay.
and the crest of the trapezium and the hook of the hamate on the lateral and medial sides of the distal row. Let's detail their attachments.
The 4 corners.
Exactly. The tubercle of the scaphoid gives attachment to the flexor retinaculum and a few superficial fibers of the abductor pollicis brevis.
Okay.
The pisiform is a major anchoring point. It receives the insertion of a flexor carpi ulnaris muscle. The source explicitly states that the pisiform is a sesamoid bone lying within the tendon of the flexor carpi ulnaris.
So the pisiform is essentially a sesamoid in the FCU tendon, acting as a lever and an attachment hub. We'll come back to sesamoids later too.
Right. It also provides attachment for the flexor retinaculum and its superficial slip, the abductor digiti minimi muscle, and the extensor retinaculum on its dorsal aspect.
Busy little bone.
It is. The crest of the trapezium is a critical origin site for the 3 muscles of the thenar eminence, the muscle bulk at the base of your thumb. The abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis.
Thenar muscles.
Yes. The edges of the groove on the trapezium give attachment to the 2 layers of the flexor retinaculum. The lateral surface attaches the lateral ligament of the wrist joint, and the groove itself houses the tendon of the flexor carpi radialis. The hook of the hamet's tip gives attachment to the flexor retinaculum. Its medial side provides attachment for the flexor digiti minimi and the opponens digiti minimi, two muscles of the hypothenar eminence, the muscle bulk at the base of your little finger.
So the thenar muscles anchor to the trapezium crest, hypothenar muscles to the hamate hook, and these pillars also form the attachments for the strong flexor retinaculum, which forms the roof of the carpal tunnel. Makes sense. Speaking of connections, how do these carpal bones articulate with each other, the radius and the metacarpals? Must be a complex web.
It is a complex system of joints. Each carpal bone articulates with one or more neighbors. Let's run through them. The scaphoid articulates with the radius proximally, lunate medially, trapezium and trapezoid distally, and capitate distomedially.
5 connections for the scaphoid.
Yes. The lunate articulates with the radius proximally, scaphoid laterally, triquetral medially, capitate and hamate distally.
5 for the lunate, too.
Right. The triquetral articulates with the pisiform on its palmar surface, lunate laterally, hamate distally, and the articular disc of the inferior radial ulnar joint proximally.
4 for the triquetral.
The pisiform articulates only with the triquetral.
Just 1.
Moving to the distal row. The trapezium articulates with the scaphoid proximally, the first and second metacarpals distally, and the trapezoid medially.
4 again.
The trapezoid articulates with the scaphoid proximally, trapezium laterally, capitate medially, and the second metacarpal distally.
Another 4.
The capitate, being central and the largest, articulates with multiple bones, scaphoid and lunate proximally, hamate medially, trapezoid laterally, and the second, third, and fourth metacarpals distally.
Wow, 7 articulations for the capitate.
It's the keystone. The hamate articulates with the lunate and tricurtal proximally, capitate laterally, and the fourth and fifth metacarpals distally.
5 for the hamate. That's an incredibly intricate network of articulations within the carpus, allowing for the complex gliding and limited rotational movements of the wrist. How do these bones ossify? They start as cartilage, right?
Yes. The carpal bones ossify entirely from secondary centers, meaning they are cartilaginous at birth. The source provides a figure showing the approximate time of appearance for the ossification centers, typically starting with the capitate and hamate around the first year of life.
Capitate and hamate first.
Right. The centers then appear sequentially for the triquetral, lunate, trapezium, trapezoid, and finally the scaphoid, usually around the 5th to 6th year, though the pisiform appears much later, around 9-12 years. These bones are largely cartilaginous in young children and don't fully ossify until adolescence.
So pediatric wrist radiographs look very different from adult ones because most of the carpal structure is cartilage. Makes sense. What are the key clinical points regarding the carpal bones? Scaphoid fracture is a big one, isn't it?
Yes. Fracture of the scaphoid bone is quite common. It typically occurs through the waist of the bone, the narrow middle part, at a right angle to its long axis. The usual cause is a fall on the outstretched hand or a direct impact on the fingertips. Clinically, this presents with tenderness and swelling in the anatomical snuff box, that triangular depression on the back of your wrist at the base of the thumb.
Anatomical snuff box tenderness, classic sign.
Yes. There's also pain when you tap along the long axis of the thumb and index finger. The source emphasizes the critical importance of scaphoid fractures because they have a high liability for non-union failing to heal properly and a significant risk of avascular necrosis of the proximal part of the bone.
Avascular necrosis means the bone tissue dies due to lack of blood supply. Why is the scaphoid so prone to this? It seems like a small bone to have such a big problem.
Well, the source explains this is due to the bone's unique blood supply pattern. The main nutrient arteries often enter the bone through the palmar tubercle and the dorsal surface of the body. However, in a significant percentage of individuals, around 13% based on some studies, both vessels may enter only through the distal half or the tubercle.
So the blood supply comes in from the bottom half mostly.
In many people, yes. So if the bone fractures through the waist, which is the narrow central part, the blood supply to the proximal half, the top bit, can be completely interrupted, leading to avascular necrosis of that segment.
So the bone's internal plumbing, how the blood vessels are arranged, makes it uniquely vulnerable to losing blood flow after a fracture through its middle. That's a crucial anatomical detail explaining the clinical outcome.
Wow.
It's a direct link between microanatomy and clinical consequence. The source notes that delayed or non-union of a scaphoid fracture may be treated later like osteoarthritis if it causes persistent pain and disability. Another important clinical issue is dislocation of the lunate bone.
This can be produced by a fall on an acutely dorsiflexed hand with the elbow flexed. The lunate is typically displaced anteriorly towards the palm side into the carpal tunnel.
The carpal tunnel is that space at the wrist containing tendons and the median nerve. So a dislocated lunate is pushing directly on the median nerve.
Exactly. The lunate is located deep to the median nerve within the carpal tunnel. When it dislocates anteriorly, it compresses the median nerve, leading to symptoms characteristic of carpal tunnel syndrome, such as numbness, tingling, and pain in the thumb, index, middle, and half of the ring finger.
Right.
Severe compression can also affect the muscles supplied by the median nerve in the thumb's thenar eminence, potentially leading to ape-like deformity of the hand, which is a flattening of the thenar muscle bulk due to muscle wasting.
A dislocated lunate directly impacting the median nerve, causing carpal tunnel symptoms and affecting thumb muscle function. That's a clear chain of events linking bone displacement to nerve dysfunction. Nasty.
It perfectly illustrates the tight anatomical confines of the carpal tunnel and the vulnerability of its contents.
Okay, from the carpus, let's move forward into the body of the hand, the metacarpal bones.
The metacarpal bones. These are the 5 miniature long bones that form the structure of your palm. They are numbered from lateral to medial, 1st through 5th, starting with the thumb.
Thumb is number 1.
Right. Each metacarpal has 3 main parts. A head at the distal end, forming your knuckles, a shaft, and a base at the proximal end, articulating with the carpal bones. The heads are rounded, with the articular surface extending further forward and backward than side to side, and more onto the palmar aspect than the dorsal. When you make a fist, the heads of the 2nd through 5th metacarpals are clearly visible as your knuckles.
Right.
The shaft is concave on the palmar surface, creating space for the flexor tendons, and typically has a flat triangular area on its dorsal surface distally. The base, where it meets the carpus, is irregularly expanded.
5 mini long bones forming the palm. How do these differ from the bones in our foot, the metatarsals? They sound similar. The source provides a helpful table comparing them.
Yes, the table lists 4 key differences. First, the shape of the head and shaft. In metacarpals, they are flattened from side to side, while in metatarsals, they are more prismoid, like a triangular prism shape.
Okay.
Second, the thickness of the shaft. In metacarpals, the thickness is relatively uniform, while in metatarsals, the shaft tapers, becoming thinner distally. Third, the dorsal surface of the shaft. In metacarpals, it has that elongated, flat, triangular area distally, whereas in metatarsals, the dorsal surface is uniformly convex. Fourth, the shape of the base. The base of a metacarpal is irregularly expanded, while the base of a metatarsal appears to be cut sharply and obliquely.
Flattened versus prismoid head shaft, uniform versus tapering thickness, dorsal surface shape, and base cut. Those are distinct characteristics. Now let's look at the characteristics of each individual metacarpal, as they're not all identical, especially the thumb one.
The first metacarpal, the thumb metacarpal, has several unique features. It's the shortest and stoutest of all 5. Its base has that distinctive concavo-convex, saddle-shaped articular surface we saw articulating with the trapezium.
Right, the saddle joint.
Yes. The dorsal surface of its shaft is uniformly convex, unlike the others. Its head is less convex and broader side to side than the finger metacarpals, and has impressions on the palmar corners for sesamoid bones.
Shorter, stoutest, saddle base, uniformly convex shaft, broader head with sesame-like spots. Got it.
Right. And here is its most significant peculiarity. The source states that the first metacarpal bone is rotated medially through 90 degrees relative to the other 4 metacarpals.
Rotated 90 degrees.
Yes. This 90-degree rotation is fundamental because it orientates the thumb, so its movements, abduction-adduction, moving away from towards the palm, and flexion-extension, moving across the palm, occur in planes at right angles to the corresponding movements of the other fingers. This anatomical arrangement is absolutely essential for the thumb's ability to oppose the fingers. The first metacarpal also does not articulate laterally with the second metacarpal.
That 90-degree rotation and its saddle joint are what give the thumb its unique and critical function of opposition. Makes perfect sense. What about the specific features distinguishing the other metacarpals, 2 through 5?
The second metacarpal's base is notable for being grooved from front to back on its proximal surface, and the medial edge of this groove is larger than the lateral. The third metacarpal's base is identified by a prominent styloid process that projects upwards from its dorsolateral corner.
Styloid on the third.
Right. The fourth metacarpal's base has 2 small oval articular facets on its lateral side for articulating with the third metacarpal, and on its medial side it has a single elongated facet for articulating with the 5th metacarpal. The fifth metacarpal's base has an elongated articular strip on its lateral side for the fourth metacarpal, while its medial side is non-articular and features a distinct tubercle.
Each metacarpal base has specific facets and features that help in identifying and side determining it. Speaking of attachments, where do muscles anchor to these palm bones? I know the interosseous muscles are primary here, the ones between the bones.
Yes, the main attachments on the shafts of the metacarpals are for the palmar and dorsal interosseous muscles, which are key for abducting and adducting the fingers. The palmar interosseous originate from one metacarpal each, except for the third metacarpal.
Ah, the third is different.
Yes. The dorsal interosseous are bipinnate muscles that arise from the adjacent sides of two metacarpals.
So the third metacarpal shaft only gives origin to dorsal interosseous, not palmar ones.
Okay, that's correct. There are also important attachments for specific muscles, particularly on the first and fifth metacarpals. On the first metacarpal, the opponent's pollicis muscle is inserted along the radial border and anterolateral surface of the shaft. The abductor pollicis longus muscle is inserted on the lateral side of the base. The first palmar interosseous muscle arises from the ulnar side of the base.
Thumb muscles anchoring to the first metacarpal. What about the others?
On the second metacarpal, the flexor carpi radialis muscle is inserted onto a tubercle on the palmar surface of the base. The extensor carpi radialis longus muscle is inserted on the dorsal surface of the base. The oblique head of the adductor pollicis muscle arises from the palmar surface of the base. On the third metacarpal, a slip from the flexor carpi radialis is inserted on the palmar base. The extensor carpi radialis brevis muscle is inserted on the dorsal base just beyond the styloid process. Both heads of the adductor pollicis muscle have origins related to the third metacarpal. The oblique head from the palmar base, also from second metacarpal, and the transverse head from the distal 2/3 of the palmar shaft surface.
So the adductor pollicis, the muscle that pulls the thumb towards the palm, has origins spread across the second and third metacarpals.
Interesting.
It does. As noted, the fourth metacarpal shaft primarily serves as origin for interosseous. On the fifth metacarpal, the extensor carpi ulnaris muscle is inserted onto the tubercle at the base, and the opponent's digiti minimi muscle is inserted along the medial surface of the shaft.
Precise origins and insertions on these palm bones guiding finger and thumb movements. What are the articulations at the bases of the metacarpals, connecting them to the carpus and each other? Each metacarpal base articulates with one or more carpal bones and often with adjacent metacarpals. Let's run through them again. The first metacarpal articulates only with the trapezium, forming that vital saddle joint for the thumb.
Just the one carpal.
Right. The second metacarpal articulates with the trapezium laterally, the trapezoid centrally, the capitate medially, and also with the third metacarpal medially.
3 carpals and the next metacarpal.
Yes. The third metacarpal articulates primarily with the capitate proximally, and with the second and fourth metacarpals laterally and medially.
1 carpal, 2 metacarpals.
Correct. The fourth metacarpal articulates with the capitate laterally and the hamat medially, proximally, and with the third and fifth metacarpals laterally and medially.
2 carpals, 2 metacarpals.
And the fifth metacarpal articulates only with the hamat proximally and the fourth metacarpal laterally.
1 carpal, 1 metacarpal. A specific set of articulations at the carpal metacarpal joints, contributing to the overall shape and flexibility of the palm arch. How do the metacarpals ossify?
The shafts of the metacarpal bones ossify from one primary center each, appearing around the 9th week of development. They also have secondary centers of ossification, but the location differs between the thumb metacarpal and the finger metacarpals.
Ah, another thumb difference.
Yes. For the second, third, fourth, and fifth metacarpals, the secondary center appears in the head during the second, third year and fuses with the shaft around 16-18 years. However, for the first metacarpal, the secondary center appears in the base during the second, third year and also fuses around 16-18 years.
So secondary center in the head for the fingers, but in the base for the thumb metacarpal. Another unique developmental aspect of the thumb ray. What are the clinical points related to the metacarpals? Fractures seem likely.
Yes. Fracture of the base of the first metacarpal is a specific type known as Bennett's fracture.
Bennett's fracture.
It's typically caused by a force directed along the long axis of the bone, like hitting something hard with the thumb. This fracture involves the anterior part of the base and can lead to characteristic symptoms. The thumb being pulled into a semi-flexed position, an inability to effectively oppose the thumb, and difficulty clenching a full fist.
Bennett's fracture specific to the thumb metacarpal base and functionally limiting. Got it.
Yes. Other metacarpals can fracture from either direct or indirect violence. Direct violence, like a crushing injury, usually causes the fractured segment to be displaced forwards. Indirect violence, like punching a solid object, often results in a fracture through the neck of the metacarpal, just below the head. These are frequently displaced backwards and are sometimes called a boxer's fracture.
Boxer's fracture through the neck, common from punching. Makes sense. The source also emphasizes the structural importance of the third metacarpal. Why that one?
Yes, the third metacarpal is the longest, and the source notes that the axis of abduction and adduction of the digits passes longitudinally through its center. This means that when you spread your fingers apart, abduction, or bring them back together, adduction, the movement is referenced to the third finger and its metacarpal as the central axis.
So the third metacarpal is the pivot point for spreading and bringing the fingers together. The midline of the hand, essentially.
Exactly.
Okay. From the palm bones, let's move to the most distal bones of the upper limb. The phalanges, the bones of your fingers and thumb.
The phalanges. There are a total of 14 phalanges in each hand. Each finger has 3 phalanges. A proximal phalanx closest to the palm, a middle phalanx, and a distal phalanx forming the fingertip.
3 per finger.
Right. The thumb, however, only has 2. A proximal and a distal phalanx.
Only 2 in the thumb.
Correct. Structurally, each phalanx has a base, proximal end, a shaft, and a head, distal end. The base of a proximal phalanx has a single concave oval facet designed to articulate with the rounded head of a metacarpal bone, forming the metacarpophalangeal MCP joint. Okay?
The base of a middle or distal phalanx, however, has 2 small concave facets separated by a smooth ridge, shaped to articulate with the pulley-shaped head of the pharynx proximal to it, forming the interphalangeal IP joints.
So the base shape tells you whether it's articulating with a metacarpal head, one big facet, or a phalanx head, 2 little facets with a ridge. Clever distinction.
That's the key difference in the bases. The shaft of each phalanx is relatively straightforward. It tapers towards the head, is convex from side to side on its dorsal surface, and is flattened side to side but gently concave in its long axis on the palmar surface.
Okay.
The head shape varies depending on the phalanx. The heads of the proximal and middle phalanges have a pulley-shaped articular surface, allowing for flexion and extension at the IP joints. The heads of the distal phalanges are unique. They are non-articular and are marked anteriorly by a rough, horseshoe-shaped tuberosity.
Horseshoe tuberosity on the very tip bone. Why is that there? The source notes this tuberosity is crucial because it supports the sensitive pulp or tip of the finger or thumb, providing a stable base for that richly innervated area.
It supports the fingertip pad. Makes sense. What are the key muscle and tendon attachments on the phalanges? Must be where everything ends up.
Pretty much, starting at the most distal point on the base of the distal phalanx. The flexor digitorum profundus muscle, one of the deep forearm flexors, is inserted on the palmar surface. This is its terminal insertion point, pulling the distal phalanx to flex the DIP joint, the last joint.
Okay, FDP goes all the way to the fingertip.
Right. On the dorsal surface, the 2 side slips of the digital expansion fuse together and insert, extending the attachment of the lumbrical and interossea muscles to this distal bone.
Right, that complex extensor mechanism. What about the middle phalanx?
On the middle phalanx, the 2 slips of the flexor digitorum superficialis muscle are inserted on each side of the shaft. The source explains that these slips split around the tendon of the flexor digitorum profundus before they insert.
FDS splits and attaches to the middle phalanx, while FDP continues deeper.
Got it. Yes. The fibrous flexor sheath, which forms a tunnel holding the flexor tendons close to the bone, is also attached to the sides of the shaft of the middle phalanx. A major part of the extensor digitorum muscle, the main finger extensor, is inserted on the dorsal surface of the base of the middle phalanx via the dorsal digital expansion.
And the proximal phalanx.
On the proximal phalanx, the fibrous flexor sheath is attached to the sides of the shaft. Crucially, parts of the lumbrical muscles and interossei muscles are inserted on each side of the base of the proximal phalanx. These muscles contribute to the dorsal digital expansion and play a complex role in finger movement, allowing flexion at the MCP joints and extension at the IP joints.
Lumbricals and interossei leveraging the extensor expansion via the proximal phalanx.
Okay, what about specific attachments on the thumb and little finger proximal phalanges? They often have unique muscles. They do. On the lateral side of the base of the thumb's proximal phalanx, the abductor pollicis brevis and flexor pollicis brevis muscles are inserted. On the medial side, the adductor pollicis and the first palmar interosseous muscles are inserted. On the dorsal surface of the base, the extensor pollicis brevis muscle is inserted.
Thumb muscles attaching all around its proximal phalanx base.
Yes. For the little finger, on the medial side of the base of the proximal phalanx, The abductor digiti minimi and flexor digiti minimi muscles are inserted.
A detailed breakdown of all those smaller intrinsic hand muscle attachments to the phalanges, contributing to fine motor control. How do the phalanges ossify?
The shafts of the phalanges ossify from a primary center each. These centers appear earliest in the distal phalanges around the 8th week of development, then in the proximal phalanges around the 10th week, and finally in the middle phalanges around the 12th week.
Distal first, then proximal, then middle. Interesting order.
It is. Each phalanx also ossifies from a secondary center, which appears for the base during 2-4 years of age and fuses with the shaft during 15-18 years.
So, primary center in the shaft, secondary center in the base for all phalanges, but the primary centers appear first in the distal phalanges.
Okay. What are the clinical points related to phalanges? Any specific infections or issues?
Yes, the source notes an interesting difference in the location of infections in the metacarpals and phalanges between children and adults. In children, infections like tuberculosis or syphilis in these bones are typically located in the middle of the diaphysis, the shaft, rather than the metaphysis, which is the usual site for osteomyelitis in kids' long bones like the humerus or femur.
Why is the location different in the hand-foot bones compared to other long bones in children? That seems odd.
Well, the anatomical explanation given is that in children, the nutrient artery entering the shaft of a metacarpal or phalanx immediately breaks up into a plexus upon reaching the medullary cavity, distributing the blood supply, and thus any blood-borne infection, more widely within the shaft rather than concentrating it at the metaphysis.
The plumbing again. Exactly. In adults, the chance of such infections is minimized because the role of the nutrient artery as the major blood supply is replaced by periosteal vessels.
So the specific pattern of blood vessel branching in children's metacarpals and phalanges explains why infections might settle in the shaft rather than the typical metaphysis. That's a specific but important anatomical detail. Very neat.
It is. The source also mentions variations in the thumb's phalangeal structure. Occasionally, a thumb may possess 3 phalanges instead of 2.
3 bones in the thumb.
Yes. In such cases, the first metacarpal bone also shows a variation. It has 2 epiphyses, one at each end, unlike the usual one at the base. Rarer still, the first metacarpal can bifurcate distally, leading to polydactyly or 6 digits. The source describes the scenario where the medial branch of the bifurcated metacarpal has no distal epiphysis and articulates with 2 phalanges, while the lateral branch has a distal epiphysis and articulates with 3 phalanges.
Developmental anomalies like a 3-phalange thumb or polydactyly linked to variations in metacarpal structure and ossification patterns. Fascinating insights into bone development gone differently.
Indeed. Finally, the source notes that the commonest fracture in the entire hand is a fracture of the distal phalanx, particularly of the middle finger. The recommended simple treatment for this is buddy splinting, splinting the injured phalanx to the adjacent healthy finger for support and protection.
Buddy splinting, simple and effective for a common injury. Just tape it to its neighbor.
Precisely.
We have now meticulously worked our way through every single bone of the upper limb, detailing their structures, attachments, development, and clinical implications based on the sources provided. Before we conclude, the source includes a specific section on sesamoid bones. What are these?
Sesamoid bones are small, rounded masses of bone located within certain tendons, where those tendons are subjected to considerable pressure or friction as they pass over a bony surface. They are variable in their presence, and the name sesamoid comes from the Latin word sesamum, meaning seed-like, reflecting their appearance.
Little bony seeds embedded in tendons at pressure points. Where are they typically found in the upper limb, according to the source?
The source notes several locations. First, the pisiform bone itself is often regarded as a sesamoid bone, lying within the tendon of the flexor carpi ulnaris muscle, as we discussed earlier.
Right, the pisiform again.
Beyond that, there are always 2 sesamoid bones found on the palmar surface of the head of the first metacarpal bone, embedded within the tendons of the muscles acting on the thumb, specifically flexor pollicis brevis and adductor pollicis.
Always 2 at the base of the thumb, metacarpal, on the palm side under the knuckle. Okay.
Yes. There is also 1 sesamoid bone found in the capsule of the interphalangeal joint of the thumb in about 75% of subjects. Similarly, one is often found on the ulnar side of the capsule of the metacarpophalangeal joint of the little finger in about 75% of subjects.
Thumb IP joint and little finger MCP joint. Pretty common.
Yes. Less frequently, they may be found on the lateral side of the metacarpophalangeal joint capsule of the index finger, and occasionally at other metacarpophalangeal joints.
So besides the pisiform, they're most consistently found around the thumb joints and sometimes around the little finger ACP joint, corresponding to areas of high tendon pressure and leverage.
That's their typical pattern of occurrence in the hand. They act like little pulleys or spacers.
We have truly gone deep, covering every feature, attachment, ossification detail, clinical point, and peculiarity listed in the source material, fulfilling our mission to understand these bones like true professionals. To consolidate, the source provides a section with facts to remember. Let's quickly highlight those key takeaways. What absolutely must we remember?
These are the points the source wants etched into memory. First, the critical relationship between the humerus and the axillary, radial, and ulnar nerves, making them liable to injury with humeral fractures, are ARM mnemonic.
Axillary neck, radial midshaft, ulnar medial epicondyle.
Got it. Second, the location of the radial pulse palpated close to the lower end of the shaft of the radius. Third, that the pisiform bone is a sesamoid bone located within the tendon of the flexor carpi ulnaris muscle. Fourth, the unique characteristics of the first metacarpal, it's the shortest, strongest, angled for opposition of the thumb, and has its secondary ossification center in the base. And fifth, the importance of the third metacarpal, it's the longest, and crucially, the axis of abduction and adduction of the digits passes through its center.
Those are excellent high-yield facts that summarize some of the most important functional and clinical points we've covered. We've explored the unique peculiarities of the clavicle, the complex muscular landscape anchored by the scapula and humerus, the forearm bone's role in stability and rotation, the intricate architecture of the carpus and metacarpals, enabling diverse hand movements, and the finer details of the phalanges and sesamoids. We've woven in how these structures develop and what happens when things go wrong, aiming for that comprehensive understanding.
That level of detail, connecting structure to function, development, and clinical consequence, is really the foundation for mastering this anatomy. By methodically working through the source material, we've built that comprehensive picture, hopefully.
It really underscores how no detail is too small when understanding the functional mechanics and potential vulnerabilities of something as complex as the upper limb. So, as we wrap up this incredibly detailed deep dive into the skeletal framework of the upper limb, here is a final thought to consider. Given the remarkable precision with which each bone's shape, articular surface, and attachment point is designed to facilitate specific movements and bear loads, how might subtle, perhaps even imperceptible, variations in these structures, developmental differences, minor injuries that healed imperfectly, or age-related changes accumulate over a lifetime to influence a person's overall upper limb function, susceptibility to injury, or even the way they interact with the world?
That's a great question. It reminds us that anatomy isn't static, is it? It's a dynamic blueprint influenced by development, use, and time, with individual variability adding another layer of complexity. Something to think about.
Indeed. Thank you for joining us on this deep dive into the bones that allow us to reach, grasp, and manipulate our world.
We hope you found this detailed exploration valuable.
We'll see you on the next deep dive.